Did we see this ECG last class?
Yes,
Anybody
sir.
remember that?
Yes,
You saw
sir.
this? Okay, we have finished seeing that. Okay. This I think you have not seen. Okay.
Yes.
Okay. Name the gadget shown here. Can you identify this?
Maska.
Second generation.
It's a Baska mask. Very
Bas-
good. How do you say it is a Baska mask? Baska mask. Okay. Next question is, to which generation does it belong to? Is it a second generation or a third generation?
Third generation.
It's a third generation Baska mask. Okay. So, what are the parts of this? Can you name the parts of this?
So it has a integrated bite block,
Okay.
suction and piece,
Okay.
gastric port.
Very good. Does it have 2 tubes or 3 tubes?
2 tubes.
2 tubes.
2 tubes. Only 2 tubes, not 3 tubes. See, if you see here, you can see one tube like here, second one is here, third one is here. Are you not seeing that?
Yes, sir.
Yes, sir.
So what is the purpose of these 3 tubes? What is the purpose of this central tube?
Central tube is ventilation tube.
Ventilation tube.
The
the-
angle piece is for suction.
Suction. What is the purpose of this tube then? It will also have some opening here. This is for air inlet to the stomach, so that you can suction it easily. Earlier versions which have only 2 tubes like your Proseal, this tube may collapse. They may not be able to suck it completely. So what they do is they allow air to go in. This tube will suck out the angle you can suck out, so that the constant suction effect can be maintained. Okay. So if you see here, these are all the parts. The center one is the airway channel. Okay, this whole red thing is the bite block, and this is the suction angle piece. This is called the cuff orifice, and this is the pharyngeal drainage system. This is the cuff for the device. So this is the opening, and what is this?
Tab.
It's a tab which you can pull to adjust the positioning of the cuff. Okay, that is not mentioned here, but they may sometimes, if they show you the real Baska mask, they may try to identify this. This is the cuff tab which can be pulled to adjust the positioning of the mask in the pharynx. Okay, so who designed this? Who are the people who designed this? Any idea? Which country they belong to? Nationality of the persons who designed this? It is a pride for us.
Indian.
They are Indians. Okay? So these are the 2 anesthetic couples who are settled down in Australia, Dr. Kanag Baska and Meena Baska. Okay, so these are the 2 people who designed the whole thing. So this is a pride for us that it was designed by our own people. But they are settled in Australia. They didn't do it in India. What is seen in this USG image?
Supraclavicular.
Supraclavicular. Huh? Supraclavicular means what are the structures you are seeing roughly? Used to locate brachial plexus in supraclavicular region. Okay, so you can see one circle here, another circle here, another circle here.
Interscalene block.
Interscalene. Interscalene is
sir.
between 2. You can see here, this is the subclavian artery, the large one. We have the first rib. We have the pleura here down. This is the pleura. This is the first rib. These are the 3 plexus, upper, middle, and lower brachial plexus. Okay. So, Subclavian artery, trunks of brachial plexus, first rib and pleura. These are the substances that are seen. What is in-plane approach? Huh? Nowadays, all of you are experts in using ultrasound, isn't it? Without ultrasound, you are not able to do anything. Central line placement or blocks. All of you need only ultrasound. No anatomical landmark guided plexus are not taught. Blocks are not taught nowadays. So there was no in-plane and out-plane description.
Along the line of the probe.
Probe or the flow, the array of this thing, the spread of the in-plane approach is a technique that positions the needles and transducer in the same place as the ultrasound beam. Okay, the needle is inserted from the side of the transducer. What are the complications of the block of this supraclavicular brachial plexus block?
Pneumothorax,
Artery or
Arterial injury.
arterial injury.
vascular injury, nerve injury, and pneumothorax. Okay, so vascular damage, hematoma, pneumothorax, hemidiaphragmatic paralysis because of which nerve palsy? Phrenic nerve palsy, hoarseness, Horner syndrome, local anesthetic toxicity, nerve damage. All these things we have to keep in mind. Describe the findings in this X-ray.
Left-sided
Left-sided pneumothorax. That's a diagnosis. Findings in the X-ray means not only the diagnosis, but description also
Absence
has
of
to be done.
bronchosvacular markings.
Absence of bronchosvacular masking on the left side. Then what about the airway?
with the heart
Trachea.
to the right side, with the deviation of trachea to the
Air shadow of the trachea is shifted to the right.
right side.
What is this piece of tissue here?
Collapsed lung.
It's
Collapsed
a
lung.
collapsed lung. So the diaphragm, the mediastinum is also put to the right side, opposite side. So patient's details and side markings, are they seen in this? Whenever you are given any X-ray in the practical exam, first you have to say whether patient's name, demographic details have to be described. Just like when you are given an ECG and asked to describe, you must say, look for the patient's name, age, the time when the ECG taken. Just like that in X-ray also, you must see whether there is a name of the patient, side mark, whether right and left. Okay, so that is the first thing. Here it is not given, number one. Orientation, X-ray, it is X-ray chest PA view. Image quality, good exposure, penetration and position. So the examiner may ask you, how do you know that the patient's chest has been properly positioned for this X-ray?
The trips more than 8.
Huh?
The visualization of the trips more than 8 in its inspiration.
That is for penetration and exposure. The position.
The medial end of
chest is-
clavicle should be
the gap between the two medial ends of the clavicle should be equal from the midline. Okay, if it is more wider on one side and shorter on the other side, that means the chest is rotated. Okay, so the ribs number you can count is for exposure and penetration, not for positioning. The positioning, you have to see the distance or the gap between the two medial ends of the clavicle and see and compare it with the imaginary midline. And bony structures are normal. Airway and lungs, trachea shifted to the right inside the thorax. Absence of bronchosvacular markings on the left hemithorax. Collapsed lung near the heart shadow. Evidence of air in the left pleural cavity. Then cardiac shadow pushed to the right. Mediastinal shift to the right. Then flattening of diaphragm. This is another important thing in the pneumothorax. So, what is the significance of this flattening of the diaphragm? Pin drop silence. Why? It means it's a tension pneumothorax. The pressure is so high, the diaphragm has been flattened. Okay. So this is a tension pneumothorax left side with mediastinal shift to the right side. That is the final correct diagnosis. What are the causes of this condition?
Chest injuries.
Chest injury, hip fracture.
Penetrating injury to the chest,
Penetrating.
not just a blunt injury will mostly not produce. Okay, blunt and okay, sometimes blunt also can be producing this. Positive pressure ventilation with PEEP, procedures such as lung biopsy, nerve block, or central venous line placement. COPD patients, spontaneous pneumothorax can happen if there is a bulla. Hyperbaric oxygen therapy, improper connection of one-way flutter valves and CPR. All these things can cause pneumothorax. How to treat this condition? What is the treatment of
Needle.
this? It's a medical emergency. If it is very acute, the patient is hemodynamically, always you must classify. It is needle is not the answer. Needle, thoracentesis, decompression is the emergency treatment, but that will not release the tension. That will to reduce the tension to some extent, but it will not completely evacuate the air that is collected there. So the treatment needle decompression in acute severe cases, then you have to go for intercostal drainage in the form of chest tube diffusion or sometimes open thoracostomy if the patient is already intubated and he develops pneumothorax because of paratrauma, because of high PEEP or airway pressures. What is the advantage of a 3-bottle drainage system? When you do the ICD drainage, intercostal drainage, how many of you have seen a 3-bottle drainage system or not seen a 3-bottle drainage system? All of you have seen?
No, sir.
Okay. It's 3-bottle drainage system, you'll have 3 bottles connected with each other. Okay, effective for pleural fluid and pneumothorax. You can accurately measure the fluid that is being drained. Low risk of fluid reflexing back into the thoracic cavity. And then you can use an adjustable suction pressure and you can detect air leaks. It is a latex-free patient tubing, so latex allergy can be avoided. And you have a filtered water seal, which will not cause any infection. Okay, these are all the advantages of 3-bottle systems. What is shown here?
Circle of Willis.
Circle of Willis.
Circle of Willis, very good. The circle of Willis. Name the various vessels forming the circle of Willis.
Basilar artery,
Basilar
vertebral artery.
Basilar
Vertebral
artery.
artery.
Circle of Willis. See, this is the vertebral artery.
Anterior cerebral
joining to
artery.
form the this is dividing into 2 basilar arteries. Then it is connected with the
Superior cerebral artery.
So middle cerebral, anterior
Anterior
cerebral,
cerebral,
posterior
and
cerebral,
posterior
anterior
cerebral,
communicating,
communicating
posterior
artery and
communicating.
Posterior communicating.
Okay. Name the different areas supplied by each vessel. What does middle cerebral supply? What are anterior cerebral? What does the posterior cerebral supply?
Middle cerebral supplies.
Middle cerebral supplies what?
Parietal lobes.
Parietal. இங்க லொகேஷன் பார்த்தாலும் சொல்லலாம் frontal, parietal, temporal அவ்வளவுதானே இருக்கு. ACA supplies the
Frontal, ACA.
superior middle parts of cerebral hemispheres. Middle supplies the lateral side and of hemispheres and internal capsule. That is why you get hemiplegia if there is an injury to middle cerebral or a clot in the middle cerebral. And PCA, posterior cerebral, occipital and medial side of temporal lobes. What factors auto-regulate cerebral blood flow? What are the factors governing cerebral blood flow? That is another way to ask this question.
Hypothermia.
Hyperthermia. Okay, it can be classified always. Myogenic factors, neurogenic, metabolic, and endothelin. That is how you must classify them. Myogenic, smooth muscle contraction and cell contraction. neurogenic perivascular nerve innervation, metabolic based on the carbon dioxide and oxygen and the hydrogen ions, endothelial derived factors like nitric oxide and endothelium. Okay, so these four things are the controlling factors for metabolic. What happens to autoregulation in hypertension and its significance? The patient is a chronic hypertensive. What change in autoregulation will happen?
The curve shifts to right.
Right, very good. The cerebral autoregulatory curve shifts to the right, which means the brain maintains a constant blood flow at a higher cerebral perfusion pressure than normal. This results in decreased tolerance to relative hypotension. What is pen lucida and penumbra? Yes, at least you must have heard of this penumbra.
area
area.
surrounding the ischemic area.
Pen lucida. It is also an ischemic area. The clue. So what is the difference between the two? What will happen if penumbra is not reperfused within a particular time? That will also become totally ischemic. Whereas pen lucida area, however much time you take to reperfuse it, it will completely recover. Okay, so that is a very mild ischemic area, is called pen lucida. Moderately ischemic area, which will recover completely, but within a very short span of time. If you do the reperfusion, it will recover. So that is it. The two stages of before cerebral infarction. In pen lucida, cerebral blood flow is 18 to 23 ml, where function stops but can be revived anytime with reperfusion. That is the beauty of pen lucida. Whereas penumbra, the CSF blood flow is lower than 18 ml. Function can be restored only within a short time of reperfusion. If there is a delay in reperfusing this area, this will also become an infarct. That is the difference. What is depicted in this picture? Pharmacology question now.
Three compartment models.
Three compartment model of drug distribution. Okay, that is a complete answer. Three compartment model say drug distribution. What comprises the three compartments in a body? What are all the? These are all imaginary descriptions. What components of our human body comprise these three compartments? What is compartment 1? What is compartment 2? What is compartment 3?
Vessel richest compartment.
See, if you look at this picture, bolus dose and both arrow is going into compartment 1. So where will
Central compartment.
this is the plasma, central compartment or vascular compartment. Okay, that is compartment 1. From there, it goes to compartment 2. Each compartment will take more drug when it has more blood supply. So vessel rich group will be compartment 2. Vessel poor group will be compartment 3. That is how you have to. In three compartment model, the central compartment represents only the plasma. The first peripheral compartment represents highly perfused tissues, and the second peripheral compartment represents scarcely or relatively less perfused tissues. In what way this is different from two compartment model? This three compartment model, in what way it is different?
Redistribution.
Redistribution can happen between these three compartments faster, and it will maintain the long time plasma concentration curves will show three exponential processes in three compartment model. The first one is rapid distribution to second compartment. So from plasma, it will go quickly to vessel rich group, and phase 2 slow distribution to third compartment. Whereas if two compartment model now 1 and 2, it will be interchanging between the two. There are no three phases. And the third phase is final terminal elimination. So that is the difference between 2 and 3 compartment model. You can see this is how the graph will be. So rapid distribution phase, that is A, slow distribution phase, that is B, elimination phase, that is 3. Okay, that is the 3 control. What is the difference between TIVA and TCA?
TCA, we give the body weight and height, and based on that, the machine give target control infusion of propofol infusions. And
Okay. TIVA?
That is a manually infusion rate.
Ah,
You can control
fantastic.
manually.
You have to adjust the dose every time when you think that you want to alter the level of serum concentration. So TIVA is more manual. It's usually practiced by manually controlling infusion rates to maintain a stable hemodynamic and a bispectral index value between 40 and 60. Whereas TCA, target blood and effect site concentration, can be set at the beginning itself by calculating or feeding the data into the machine. Okay, so it is automatic, computer based, whereas TIVA is manual. What is context sensitive half-life?
After
The
the
time
stopping,
at which the plasma concentration of the drug decreases.
after the stopping of
the
the
time taken to reach the
The
plasma
time taken for the
concentration
drug
to
concentration
half of the
falls
concentration.
at the end of infusion. It was designed to maintain a constant concentration. Okay? So the drug concentration should fall by half after how many minutes or hours of stopping the infusion. That is called the context sensitive half-life, because the concentration falls to 50% lower after stopping the infusion. How much time it takes, it varies between drugs. So for propofol it is about 20 minutes. For remifentanil it is only 6
2
minutes. That is the reason why patients with remifentanil start feeling the pain immediately unless you give a rescue analgesia before discontinuing the drug. Okay, so that is the importance of context sensitive half-life. What is shown here?
Rigorous diagram.
Figures diagram or cardiac cycle diagram, which is also called. Why there is no apostrophe here? Figures diagram, na, it should have been, there should be an apostrophe S. Why it is only, it is without apostrophe you write figures. What is the name of the person who designed this or who drew this? It's called Carl Wiggers, C-A-R-L, Carl, German fellow. So Carl Wiggers ங்கிறது அவன் பேரு. அதனால apostrophe போட முடியாது. Right, it is not belonging to Wiggers. The name itself is Wiggers. What information is depicted in this? For the informations you get looking at the picture, what are all the things that you are able to see?
Pressures in the atria and
Pressure, ventricular pressure, ventricular
electrocardiograph and
The side, Patina, you can see 3 pressures: aortic pressure, atrial pressure, ventricular pressure, 1 volume, ventricular volume, and ECG tracing and phonocardiogram. These are all options. This phonocardiogram is an option, but other 5 things will be there. So 3 pressures: aortic, atrial, and ventricular, 1 volume, which shows the ventricular volume, EKG tracing corresponding to the events, phonocardiogram to record the first and second heart sounds. What is the use of this Wiggers diagram? Where can it be used? It's used to teaching purpose. It's used to teach the phases of cardiac cycle to students. Okay? How do the phases correlate to the events in cardiac cycle? Like you can see the P wave, ST, all this EKG, how do they correlate with the cardiac cycle? You can see here P wave, so atrial systole, EKG, TP wave, heart sound, which is S4. Normally you don't hear the P wave in the atrial contraction sound. And the valves, semicolon valves are closed at the time, and the atrioventricular valves are open. Okay? So ventricular systole is isovolumetric contraction and isovolumic contraction. and it is represented by QRS. And we get the S1 sound, where the semilunar valves are closed and the atrioventricular valves are also closed. And ventricular systole ejection 1, you get the ST segment, and the valves open, but the AV valves are closed. It's only the aortic and pulmonary valves are open. And ventricular ejection 2, you get the T wave, T polarization. At that time also, pulmonary, aortic and pulmonary valves are open. And the ventricular diastole is represented by isovolumetric and isovolemic relaxation. There is no representation of ventricular diastole in the EKG. And you get the sound of closure of the semilunar valves, the heart sound S2, and the atrioventricular valves are also closed. Then you have ventricular diastole filling 1 and 2, early rapid filling and slow filling. And sometimes this early rapid filling may produce the S3 heart sound. So the next question is, what causes S3 and S4 sounds and their significance? Normally we hear only S1 and S2, lub dub, lub dub, lub dub. But
S3 indicates the systolic function, sir. And S4 indicates a diastolic dysfunction.
S3 indicates systolic function. Here I'm showing here ventricular diastole and S3. So S3, S4 sometimes occur due to blood flowing during early and late diastole respectively. Okay, this is how the whole thing. It is atrial contraction pushing the blood produces S4 sound in heart failure. Okay, that is why you call it as atrial gallop. S4 gallop in heart failure, the atrial kick becomes very, very important. So that S3 may be normal in children or in pregnant women or athletes. And S4 is always pathological happening in heart failure. Okay, that is the difference that you have to know. What are the phases of cardiac cycle? Isovolumetric relaxation, ventricular passive filling, atrial contraction, isovolumetric contraction, ventricular ejection. Okay, so these are all the phases of cardiac cycle. What is a mutatic mixture?
That is equal proportion of the two various blocks.
So what happens that equal proportion, if you just say bupivacaine and ropivacaine equal proportion edutha adu mutatic mixture aiduma?
Same concentration.
Okay, I'm taking
The lowest is some melting point.
Melting point.
When two drugs with different melting points are mixed in equal proportions, they attain a new melting point and remain in a semi-solid state. Then only they are called as mutatic mixture. When two drugs with different melting points are mixed in equal proportion and they attain a new melting point or temperature at which they remain semi-solid. So what does this acronym EMLA stand for?
Eutectic mixture of local
Local anesthetic.
Very good. Eutectic mixture of. Why does it require an occlusive dressing, and how long the dressing should be applied if you want to use this drug?
Half an hour to 45 minutes.
45 minutes to 1 hour, sir.
Okay.
And
Why
the
does
data
it
is
require?
for absorption, sir.
Or
the local
For
anesthesia.
cutaneous
contact with
cutaneous.
close contact within 45 minutes to 1 hour duration. What are the indications for the use of encontering?
When
For
any
IV
picture
insertion.
injections
IV cannulation.
and any lace.
It can be classified into pediatric. For IV access, circumcision have been done by that. In adults, removal of warts, skin graft, harvesting, etc. Okay. What complication can occur if applied to raw area, and how does it happen? It should be applied only to intact skin. And it should not be applied to any raw area or burn wound or like that.
Burning sensation.
Burning sensation. Is that the reason why you should not apply to raw area? It will get absorbed from that, isn't it? If you apply to raw area, it will get absorbed. So what can happen? Which component in this is it's a composition of lidocaine 2.5 and prilocaine 2.5. Which one is the culprit?
Methemoglobin, prilocaine, sir.
Prilocaine. It can cause methemoglobinemia by prilocaine present in the composition. So what is methemoglobinemia and how do you treat it? What will happen if not treated?
We will give methylene blue.
That's the treatment, okay. How much of methylene blue? Orally, intravenously, intramuscularly, rectally, inhalationally, how much, what route? Everything should be told in the answer. You must give methylene blue, solely high chew mandrakali, methylene blue, methylene blue, what is first of all methemoglobinemia? What is your understanding of methemoglobinemia? What is the change that is happening in the hemoglobin? Methemoglobinemia occurs when some or all of the iron in the hemoglobin is oxidized to, from normally it should be in the ferrous form, that is only 2 plus, okay, Fe plus plus, that is called ferrous form. Fe plus 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 3 plus, that is called ferric form, okay. Only the ferrous form can get attached to the oxygen. Ferric form, not the oxygen carrying capacity is not there for that. So the conversion of ferrous form to ferric form will be done by the prilocaine. And the matter, if it is converted from ferrous to ferric and oxygen is not being taken up by the hemoglobin, what will happen to the tissues supply?
Reduced, sir.
That will be reduced. Okay. So patient will go for anaerobic metabolism. It will develop hypoxia. Okay. So it is treated with IV methylene blue, 1 milligram per kg body weight over 5 minutes, or injection ascorbic acid. What is ascorbic acid?
Vitamin C.
Vitamin C. It is available as a liquid. All of you would have chewed ascorbic acid as a tablet. Lim C, QC, SATC, all the C tablets are available, but it is also available as 5 ml ampule of ascorbic acid, 100 milligram in each ml. So 500 milligram IV you can give slowly. This prevents hemoglobin from binding and transporting. That is the methemoglobinemia. The problem is, if not treated, it prevents hemoglobin binding and transporting oxygen, leading to hypoxia. Okay, that is the danger of. And if you put a pulse oximeter, can you find out methemoglobinemia?
The saturation will
85.
Will show the same thing. Okay, so it is very difficult to detect the methemoglobin by your normal pulse oximeter. So which instrument will help you to detect methemoglobin?
oximeter.
ABG.
Oximeter, yes. Also the carboxyhemoglobin, carbaminohemoglobin, all these things are detected only by co-oximeter and not your regular pulse oximeter, because the wavelength measured is the same. What condition is this?
TMG joint ankylosis, sir.
Joint ankylosis, unilateral or bilateral?
Unilateral.
Unilateral. You can see the gap is little more in this side than this side. The teeth are always very close
Yes,
here.
sir.
So this is a left-sided TM joint ankylosis, preventing opening the jaw completely, whereas this is moving little more. Okay? So this is a case of left-sided temporomandibular joint ankylosis, preventing mouth opening. What are the treatment options if the patient comes to the surgeons with this?
The release of the
Release of the TM joint by too many other surgeries. Only treatment is the temporomandibular joint ankylosis is various forms of corrective surgery. What are the challenges in the anesthetic management of these cases?
difficult airways, sir.
It's an anticipated difficult airway. Restricted mouth opening
Indeed.
leading to anticipated difficult airway. Possibility of blood loss because of the facial surgery. And post-op airway problems if adequate relief is not achieved by surgery. Okay. What are the options for securing the airway in this case?
Awake fiber optic intubation is the only option, sir.
Only option. Okay.
Nasal,
Awake fiber optic intubation.
nasal
Only
tracheal intubation, sir. So what are the
nasotracheal intubation. So no other option. I have never done a fiber optic intubation for this in my 20 years of experience in plastic surgery. I have done it only by other.
Blind nasal intubation.
The first comfortable option is awake fiber optic nasotracheal intubation under topical analgesia. The second is awake blind nasal intubation under topical analgesia. This is what I have done at least in about 20-30 cases of PF joint ankylosing which I have managed. And the third is retrograde intubation. That also can be done in this case. So these are the options. Don't be dogmatic that this is the only option. And the answer varave kudadu examiner.
Yes, sir.
Okay. நான் எக்ஸாமினர் இருந்தா ஃபெயில் பண்ணிடுவேன். ஏன்னா நான் I have never done nasotracheal intubation because it was not available at that time when I was in practice. Right. And the elective tracheostomy under local infiltration. That is also another option to secure the airway. Okay. What precautions to be taken during recovery? You have done the airway, secured the airway, you have proceeded with the surgery. Surgery is over. During recovery, what are the precautions you have to take? How many of you have seen or done this surgery?
No, sir.
It was not a very common surgery. Only if you are in a plastic surgeon or a dental unit, you will have the chance to anesthetize these patients. So the chances are ensure adequate mouth opening by doing a trial laryngoscopy. Okay, whenever the release is good, like 3-finger breath, normally what you want, to put a laryngoscope and see whether you are able to see up to the epiglottis. Then only you must extubate the patient. The second is if the mouth opening is not adequate, leave the ET tube in situ until complete recovery of reflexes is there. Or if it is a difficult intubation, then leave an airway exchanger with oxygenation port while removing the ET tube. Okay, so these are all the options that you have or precautions you have to take. Identify this equipment.
Pulmonary artery catheter.
Very good. Pulmonary artery catheter, also known as Swan cancer catheter, also known as flow-directed balloon tip catheter or Miot snake. What are the ports that are available? You can see there is 1 port, 2, 3 ports are available, and this is a port 4.
On
So what are
One thermodilution measurement.
this is
Injection
the thermistor port. Okay. So this is the balloon port,
Thermistor port.
thermistor port, CVP port, and pulmonary artery port. So the 4 ports are there. Describe the measurements. At what length you will, what is the total length of this catheter? At what length you will reach the right atrium? What length you will reach the pulmonary vessel, smallest vessel? Okay, its length is 60 to 110 centimeters because you can use it for children also. So pediatric smaller size, smaller length, adult maximum 110 centimeters. Diameter is 4 to 8 French. What is the relationship between French and SWG or the gauge length which you use for your vent plan? You say 18 gauge vent plan, 20 gauge vent plan. You don't say 18 French vent plan. What is the correlation or some equal values between French gauge and the SI unit of SWG? Okay, homework for next class. Balloon inflation 0.5 to 1.5 ml. Markings of 1 centimeter or 10 millimeter increments to help with the insertion. What are the uses of this catheter? Where all do you use it?
Cardiac surgeries and non-cardiac surgeries.
Cardiac surgery. Correct. Okay.
Thermodilution measurement of cardiac output, sir.
Cardiac output measurement. Okay.
RA pressure, LA pressure measurement.
Various pressure. So continuous cardiac output monitoring, you can use it. Central temperature monitoring, you can use it. Measurement of pulmonary artery pressure is also an indirect measure of the left atrial pressure. Mixed venous saturations you can measure. Estimation of diastolic filling of left heart with a normal PCWP. What are the complications of this insertion of this PA catheter? Is it recommended nowadays as a routine? Earlier,
No,
sir.
it is not recommended because of the complications only. So the usual complications of the central line insertion, arrhythmias, it can produce heart block, it can produce infection, knotting, pulmonary infarction, hypotension, hypoxia, pulmonary artery rupture, air embolism, valve damage, or incompetence. So thrombosis, pulmonary artery rupture, like line sepsis, endocarditis, these are all immediate complications and late complications. Endocarditis, inability to remove due to kinking. So the complications can be classified into early complications and late complications. What is American Spinal Injury Association classification? Based on the what we discussed in the class, I picked up this question here.
To grade the motor and sensory grading, sir.
Very good. These are agreed upon international standards for neurological classification of spinal injury. What is the basic requisite to elicit this classification? Supposing you want to assess the motor or sensory level, what type of patient you need? An unconscious patient or a conscious patient?
Conscious patient, sir.
That's good. So the classification requires clinical examination in an awake and cooperative patient. Okay, that is the most important basic requisite.
Okay.
So if a patient is head injured and also has a spinal cord injury, you cannot do this. So it requires an awake and cooperative patient. How is the level of neurological injury classified using this examination? That we have already seen by eliciting the lower spinal level with normal remaining motor and sensory function. Okay. What is the importance of this score at 72 hours post-injury? Earlier in the discussion, I told you that the primary injury and secondary injury, so up to 7 days, the injury can either progress or remain static. So what is the importance at 72 hours? The most sensitive predictor of patient's long-term prognosis. Okay. Usually after 72 hours, it doesn't progress. So if it becomes static at a particular level at 72 hours, that is indicative of the prognosis. So how spinal cord injuries divided? Describe them.
Primary.
We saw that primary and injury, complete, incomplete. Complete injuries are characterized by loss of motor sensory function in the anal and perianal region, representing the lowest segment in the spinal cord. Whereas incomplete injuries involve some degree of preserved neurological function and are subsequently described by their residual functions. Now, another very rare, not very well known, not very well taught thing. So, what do these symbols denote? These are all electrical symbols used in the various gadgets that you use in the OT or in your instruments. Any idea? No idea. Okay.
No,
So this is called double insulated. It's called class 2 type of electrical safety. Is a double insulated equipment. Then this is called the defibrillated safe. So these two things, without this human symbol, it indicates a defibrillator. They put two straight vertical lines with a horizontal line in between, that is the indicator or a symbol of defibrillation, defibrillator. So human symbol is put in between. It is a safe for human beings from current shock. The third is this is the defibrillator at CF. Now, this is another symbol. Is indicative. This is called the type B symbol. It is enclosed within a box. It's called type BF. And this is called equipotential F point. And this is again is type BF and type CF. It is enclosed. Now you will understand it better by the second question. What are electrical? I mean the third question, which is going to come. How they are classified? How electrical equipments are classified? They are classified into two types. From this, if you see, there's a classification showing B, BF, C, CF, and also class 2. So it is divided into class 1 equipment, which is earth. Fuses are also present. So if there is a short circuit making the equipment live, current will pass to earth, making the fuse blow. So this is what is called the class 1 equipment. Class 2 is double insulated, what it is called. It is not earth. So normally it doesn't produce a shock, class 2 equipment. Class 3, safety extra low voltage. There is a safety extra low voltage. So this also will not produce much of a shock. So they can be classified into these three classes, class 1, class 2 and class 3. Another type is typed in type B, which encloses class 1, class 2, class 3 equipments with a low leakage current of 0.5 milliamperes for class 1 and even lesser 0.1 milliamperes for class 2. And type BF, second category, is similar to type B but safer because patient is isolated from the circuit whenever there is a leakage. And third is the type CF, where there is a low leakage of current, even less than 0.5 and 0.1, it is 0.05 and 0.01, and it prevents microshock also. Okay, so the two classifications, class 1, class 2, class 3, then the types B, BF, CF, 3 types and 3 classes. That is the way you can remember about this safety of electrical equipment. Okay, what is shown here?
Double
lumen
tube.
Double lumen tube. That is the only answer. Everyone things the exam you must observe the picture correctly and try to name all the things that are shown. Just identifying as a double lumen tube is not the answer. Then you will get only half a mark.
With Y
There's a Y
connector.
connector. There is a Y piece connector here. Very good. What is this equipment? The surti vechirukku. Imagine this is straightened out, and this is there's a sedation to introduce it into something. There is something.
Suction catheter, sir?
Suction catheter. Very good. What type of suction catheter? What is this portion? It is not a simple suction catheter.
Closed suction.
Not closed suction. Thumb suction. You can close the suction by occluding the opening in this projection here. Okay, this is called a thumb suction. Whenever you don't want the suction effect, you will just keep it open and introduce. So during introduction to Sakti secretion, you don't close it and you just send it. Otherwise, it will get stuck to the pharynx, get stuck to the tongue and all these areas. So that is the control. And what is this? Blue. Okay. Double lumen endobronchial tube with the Y-piece, thumb control suction catheter and connector. So this is the connector for that. Okay, so all these things are there. What are the indications for its use?
Related to
One lung ventilation.
One lung ventilation, sir.
Double lumen tube patti indications nu keta always must classify
relative
it
and
into
absolute.
We
So,
must classify into absolute and relative. Okay, absolute indications are, these are all the, for lung separation is the main aim for that. So isolation of one lung from other to avoid infection or in massive hemorrhage. Then control of distribution of ventilation as in bronchopleural cutaneous fistula or surgical opening of a major conducting airway, giant unilateral bulla or cyst, tracheobronchial tree disruption, life-threatening hypoxemia due to unilateral lung disease, and unilateral bronchopulmonary lavage. These are all the absolute indications. The relative indications mainly for surgical exposure, like thoracic aortic aneurysm, pneumonectomy, upper lobectomy, which are all the lung injection. These are called high priority surgeries, where you have to do this isolation. Low priority surgeries are middle and lower lobe dissection of the lung, esophageal surgery, like esophageal cancer when you want to do a pull-through, gastric pull-through surgery, resection of esophagus, thoracic spine procedures, minimal invasive cardiac surgery, all these things these are low priority. And post-cardiopulmonary bypass status after removal of totally occluded chronic unilateral pulmonary emboli, severe hypoxemia due to unilateral lung disease. In these cases, to ventilate the normal lung, you can isolate the diseased lung. Can you identify this equipment? Looks very, very small, isn't it? Okay, this is called Mara-Rose bilumen tube for children. So when you want to do isolation of the lung, you cannot put this big tube in a small baby. So you have to go for this, what is called Mara-Rose bilumen tube for children. What is this? This also shows a tracheal lumen, a bronchial lumen, but the tube is bent here. Can you make a guess? This is a double lumen tube for patients with tracheostomy. Whenever you have a tracheostomy patient, you cannot use this tube. So you can use this through the tracheostomy hole and use this. Okay. There are a lot more. Will go for some more or not here? Okay, I will show one more and finish. This is a very interesting one. Is it a crystalloid or a colloid? What is shown here?
Crystalloid.
Crystalloid. What is a crystalloid? How do you define a crystalloid and how are they classified?
Isovolumic.
Based on tonicity, we can
Isotonic
classify
and
hypotonic, hypertonic, and isotonic.
That's the classification. What is the definition of a crystalloid solution?
it should be clear and clear solution and latex.
Guesswork எல்லாம் பண்ணக்கூடாது. A substance that forms true solution and is capable of being crystallized is known as a crystalloid. Okay. So when you heat a solution with sodium chloride, you can separate the salt. Water will sit here. But when you add salt to the water, it will disperse completely. You cannot see the salt anymore. So that's a true solution. Substance forms a true solution and is capable of being crystallized. When you heat it, you can retrieve the salt in there. Okay, that is known as, that is why it's called the crystal. It forms a crystal back. That's why it's called crystalloid, crystal-like. Okay. Solutions are categorized into hypotonic, isotonic, and hypertonic. Why this is called plasma light 148? This is the explanation for the naming of this fluid. All of you are using this, isn't it? Right, left, and center nowadays in your
Yes,
theater.
sir.
Why it is called plasma light 148?
It's absolute equal to the plasma. That value.
It is called plasma light as its osmolality is equal to plasma. contains electrolytes. This last portion of electrolyte is the light here. Contains both positively and negatively charged ions in equal concentration of 148 milliequivalents. Okay, I'll show you the composition later, that you will be able to understand. It has got the equal number of positive, negative charges ions here. Okay, what is the calorie value of the solution? Is there any calorie value in this? If you give this, does it contain any carbohydrates, starch, sugar?
No, sir.
No. So is it a 0 calorie? 21 kilocalories are still there in that. In spite of the fact that there is no major component like dextrose or anything, still it has got a caloric value of 21 kilocalories per liter. What is the purpose of sodium gluconate and sodium acetate? You can see the composition. It has got sodium gluconate and sodium acetate in this. Tomorrow when you go to theatre, read the composition. It is given in the bag.
Yes, sir.
And can you tell me what is the purpose of these two elements that are added in that? Okay, so gluconate and acetate ions are metabolized in the body to carbon dioxide and water. This utilizes hydrogen ions, producing an alkalizing effect. Okay, so it is very good for patients in acidosis. It will automatically give some alkali effect and reduce the metabolic acidosis. What is the osmolality and what are the precautions for its use? What is the osmolality? I told you here, I have not given the value specifically because the osmolality is equal to plasma.
Plasma.
What is the osmolality
295.
of plasma?
295.
295.
295, yes, it is 295. Caution is needed in patients who have hyperkalemia, example renal failure, okay, because it also has potassium. So what is strong ion difference? Strong ion difference is the difference between cations and anions at a given pH. That is called that is positively charged and negatively charged ions. What is the difference is called at a particular given pH is called the strong ion difference. Okay. Shall we stop there?
Yes, sir.
Okay.
Yes.